everyone. I'm Patricia Shampton, Director of Alumni Relations for Texas Exes, and welcome to the May Virtual Lunchtime Lecture. Thank you so much for joining us today, and thanks to our sponsor, Home Chef, for making this event possible. Our guest today is Dr. Nafkiran Shokar, and she's the chair of the Department of Population Health, a professor of population health, and the Associate Dean for Community Affairs at Dell Medical School at the University of Texas at Austin. She's here today to discuss evidence-based strategies shown to improve cancer risk and promote early detection. In more than 20 years in academic medicine, Shokar has worked as a clinician, educator, and clinical researcher. Her research interests include interventions in cancer prevention and control, shared decision-making, and community-based research to address cancer health disparities among vulnerable, poor, and underserved populations. She has developed innovative population health approaches to bridge the divide between the community, the healthcare delivery system, and public health. In addition to her institutional leadership roles, Shokar has received more than $25 million in research funding, served on several national steering committees, and currently serves as the chair of the Prevention Advisory Committee for the Cancer Prevention and Research Institute of Texas. Please help me welcome Dr. Shokar.
Thanks, Roxanne. Thank you for inviting me to present on this very important topic. As you can tell from my bio, it's a topic that's very close to my heart and something I've dedicated my career to. So, oh dear. Okay, here we go. So the title of my talk is How to Prevent Cancer and Detect It Early. And so we're going to spend the next hour kind of, hopefully I'll be able to give you some kind of big picture and specific ideas of the kinds of things that you can do in your own lives to reduce your risk. So today I'm going to start big picture, like I said. I'm going to talk about what cancer really is, discuss the epidemiology of cancer, the who, why, and the what, some big picture strategies for prevention, and then very specific actions that a person can take in their own lives to reduce the risk of cancer. And then I'm going to talk briefly about the kind of cancer prevention work that's happening at UT Austin. So cancer is as old as time. The fossil evidence shows here from over 240 million years ago, the evidence of cancer in the bone of a predecessor of turtles. So it's about being around in living things across the millennia. So a word before we get going to make sure we're all on the same page with some of the terms that we commonly use about cancer. So an overgrowth of cells is called a tumor. A tumor just means it's a lump of tissue, but it doesn't tell you anything more about it. A benign tumor is one that is not cancerous. In other words, it won't invade the surrounding tissues and it won't come back when you remove it. A malignant tumor is what we call cancerous. It invades the surrounding tissue. It has uncontrolled growth, and it can recur when it's removed, and it can also spread to distant sites that are far away from the original site where it started. And when a cancer spreads to a distant site, that's called a metastasis. So how does cancer occur? So what normally happens in our cells is that the cells grow, they divide, and they have a programmed cell death. And that's normal in all our tissues and organs. And the picture on the right kind of shows that process when it goes awry. So what causes the cells to have that normal process disrupted results in uncontrolled growth and the failure of them to die when they should. So it can start in anywhere, in any of the body's cells, this process. And what ultimately drives that change in the cell function to cause this is usually some change in the genetic material of that particular cell. And that leads to the malfunctions that cause cancer. And so how do these genetic changes occur? Well, sometimes they can be inherited from our parents. They can be caused by damage to the DNA from harmful substances in the environment. And they can also occur because when a cell divides, what happens is it duplicates its DNA, its genetic material, its chromosomes. And in that process, sometimes there's errors in what's produced. And the cell has natural mechanisms to detect and deal with those errors. And so it's able to eliminate that damaged DNA during that division. However, that ability to do that does decline with age. And then as a cell becomes abnormal and divides, often what happens is that further genetic changes occur because that process has been bypassed for detection and correction. And so additional genetic changes arise as well, which kind of can make the situation worse. And the other thing that we've learned with new scientific and basic science and lab techniques is that often these changes that happen in one cancer are very similar to changes that can happen in a cancer in another part of the body. So that has implications for treatment. So cancer is not one disease. The way we characterize cancer, we usually name it after the organ in which it originated or the cell type that it became abnormal. So examples you may have heard include carcinoma, sarcoma, which is a soft tissue tumor, leukemia, which is a tumor of the blood, lymphoma, which is the lymph nodes, myeloma, which comes from a cell in the blood, and melanoma, which is the melanocyte cell in the skin. So each cancer is really unique. So when someone says, they have skin cancer, there are multiple different types of skin cancers. And there's even more complexity beyond that because one skin cancer of the same type, for instance, a melanoma, is not necessarily the same as someone else might get because the set of alterations may be different that caused it to occur. So this kind of genetic profile and the set of alterations that happen also provide an opportunity for us to create targeted interventions that really address the abnormality that actually happened to cause the cancer. So that's really exciting on the treatment side. But today we're going to focus on the prevention side. So who gets cancer? Well, basically, as you've kind of learned, anyone who has a cell can get cancer. And the problem is each of us has trillions of cells. So that's why cancer is so common. So cancer in the US. So these are estimates that the American Cancer Society produces every year based on the data and projections. So 2024 actually is the first year that the number of cases of cancer are going to exceed 2 million. And you can see kind of the distribution across the states. Basically, the numbers are really a function of how many people live in those states. So Texas has a third highest level of cancer that's expected to be diagnosed. And over 600,000 deaths are expected this year from cancers. Now, they're from people that have been diagnosed with cancer in, a number of years earlier. Not all the people it's not all people that were diagnosed this year. So cancer increases with age. So 88% of diagnosed cancers are in people that are age 50 or older. And because of advances in treatment and also detection, there are currently 18 million folks that have had a history of invasive cancer that are alive in the US today. So let's look at what's happened. That's what's expected 2024. So what's been happening over time? Well, these two graphs show the trends in cancer new cases, which is what we mean by incidence, and cancer deaths. So if you look at the orange graph, orange line, that shows the combined kind of pattern among men and women in the US. And you can see that there was a blip in the early 90s, largely driven by lung cancer. That's when lung cancer cases peaked. And since then, there's been a gradual decline in incidence with a few little wobbles along the way. And in death rates, you can see there's been a dramatic decline over time in men and women. And there's been actually, if you look at it, about a 31% decline in the death rate. So that's the number of deaths per 100,000 population. Now, this graphic on the right shows, the top part shows incidence of new cases that are expected in 2025 in men and in women. And then the bottom row shows the number of deaths that are expected. So you can see the pattern in men and women is slightly different, but there are some commonalities. So that the commonest cancer for both is a sex-specific cancer, so breast in women and prostate in men, around 300,000. And then the next two most commonest occurring are lung and colorectal. And then melanoma is similar. Hodgkin's lymphoma is on there, and pancreatic is in men, but it's lower down in women. But then when you look at the pattern of deaths, you can see that although lung cancer is responsible for about 11% of new cases in terms of its proportion, it actually causes about 20% of deaths. So it's out of proportion to the number of cases that are diagnosed. And then you can see the pattern is pretty similar with colon, pancreas appearing next most common. So these are the things that cause deaths. And if you look at the top 5 or 4 cancers, they're responsible for about 50% of the deaths from cancer. So these are the ones that we really need to focus on when we're talking about detection and prevention. So digging into the data a little deeper for men and women separately. So in men, as you saw on the other slide, prostate cancer is the most commonly diagnosed. And if the graph has a dot for 2020, because 2020 was an unusual year and the data is skewed by the fact of the impact of the COVID pandemic on health services delivery and also in the patterns of patients seeking care. So the rates are lower, but it was because physicians weren't necessarily available to see patients, and the patients were scared to go and see the doctor. So there's a little bit of a decline you see there, and we expect that to increase again and begin to follow the graph again in 2021. So you can see that most cancers are declining in terms of their rates, but because the population is increasing, that's why we topped 2 million this year. So the rates are lower, but there's more of us, so there's more cases. And so generally melanoma is going up, but all the other ones pretty much are going down. We're not sure what's happening with prostate cancer. And so that's kind of an area of scrutiny at the moment to try and understand what's happening there. And then deaths, you can see that lung cancer deaths peaked in the 90s and they've been down. And that pattern just reflects the patterns of smoking, because smoking has declined, and we'll talk more about that a little bit later on. Again, generally the trends are down. Pancreatic cancer is steady, maybe slightly increasing. So these are the things that we watch for to kind of anticipate what to expect in coming years. And then in women, you see again, breast cancer is the commonest. Generally, most cancers are declining in the number of deaths per 100,000. There may be a slight wobble for the pancreatic cancer in women in terms of deaths, but generally, again, everything's going in the right direction. Breast cancer has been flat, and it looks like there may be a little bit of an uptick, so that's something we're watching for very carefully. So we'll see what the next year's data shows. So in terms of an individual, the lifetime risk of cancer is actually higher than one would hope or think. So if you look at the top row for both men and women, women have a 1 in 3 risk of being diagnosed with a cancer during their lifetime, and men have a slightly higher risk at 1 in 2. And then you can see kind of the pattern of risk across the cancers on the slide. Again, commonalities across genders and sex, but generally some gender-specific ones on each one. So what's happened with survival? So death rates have gone down, so presumably survival has been impacted by that. So in medicine, we really look at survival in terms of 5-year survival as far as it goes for cancer. And if you look at the top row, if you look from 1975 to almost present day, you can see that the survival from cancer has increased. And again, this is a function of early detection, but also a function of treatment advances. But there are some cancers that we haven't made as many strides as we would like to have done. And you can see dramatic changes in many of the cancers, but a couple that really stick out as not having been having those same improvements are lung cancer and ovarian cancer, as well as pancreatic cancer. So pancreatic cancer, you can see the survival rates are very low. And that's partly because it's a hard cancer to detect. We don't know how to prevent it at the moment. And the lung and bronchus, it's an effective treatment. And again, it presents late. So we'll talk more about that and some newer recommendations that hopefully will help to alter that trajectory a little bit. So prognosis. Prognosis is the estimate of survival based on characteristics when you're diagnosed. So primarily, prognosis is determined by biological traits of the cancer. So cancer type, what stage it was diagnosed at, what grade of cancer it is, whether it's what we call poorly differentiated or more differentiated, certain characteristics of the cells, what receptors they produce and things like that, which reflect the kind of genetic changes that underlie the development of the cancer. But then there's also treatment response. Some people respond better, and that may be a function of the traits of the cancer, but can also be a function of the health of the person and their age. But there's also another element that determines outcomes in particular, and these are non-medical drivers of outcomes. So these are things that is very clear when you look at from a population level perspective, that these factors also weigh into how well people especially respond to treatment or what their outcomes look like, even when you control for some of the biological factors, and they're just listed on here. So social circumstances, environmental exposures, behavioral factors such as the, risk factor kind of prevalence and activity, their access to care and the quality of care that they receive, cultural beliefs, which may determine some of the behavioral factors as well, and stress as well. Chronic stress definitely plays a role in all of this, and there are biological mechanisms through which we're now understanding more and more about how your kind of mental health and psychological state can really affect biological processes. So stage is very important when it comes to cancer. So I'm going to spend a minute to talk about stage here. So here are some of the common cancers that are diagnosed. And the graph, the bar shows the proportion of those cancers that are diagnosed at early stage versus late stage in actuality. And you can see that the regional and distant ones, these are the ones that are diagnosed at more advanced stages. And so anything with a greater proportion of the purple or the green are the cancers that are diagnosed at late stages. So you can see lung, very few are diagnosed proportionally at early stage. Same for colorectal, same for lymphoma. And if you look at pancreas, it's a very small minority that are diagnosed at an early stage. Now, why is that important? Well, this slide shows the survival and how that relates to stage. So you can see that the ones that are in situ or localized, in situ is a very early stage of the cancer. So the survival, the 5-year survival for folks that are diagnosed early, they're almost 100%, dropping off a little bit for colorectal. But if they're diagnosed late, then the 5-year survival drops dramatically. So clearly, that is an intervention point to try and shift the stage of cancer diagnosis to a much earlier stage, which can lead to less complex and invasive treatment, but also has better outcomes. So that's what we're aiming to do with prevention. So a word here about, some of the social non-medical drivers of outcomes. This graph really shows racial ethnic group survival over time in the US. And, the race ethnicity is really a surrogate for social circumstances, exposure to environmental carcinogens, and so on. So you can see that African Americans of the racial ethnic groups have the highest mortality. And the other group, the pattern is a little bit different. This is the overall pattern, but when you look by cancer, there are certain cancer types that certain groups do much worse on than other cancer types. But when you look at the average, this is what you see. So that's an important consideration as we develop our approaches to cancer. So cancer prevention. So this is basically actions that can be taken to either prevent the onset or the development of cancer. And as far as prevention goes, we have 3 different ways to intervene to shift outcomes for cancer. So one is we can reduce exposures to known risk factors. So that's one strategy. Another strategy is to detect the cancer early, even before there are symptoms. So that's screening primarily. And the third strategy is early diagnosis. Part of that is screening. Part of that is making sure that patients are aware of some of the signs and that they seek help when they experience any of these signs. So I'm going to talk about that a little bit more. So if you think about cancer development, so what happens biologically is there's a state of pre-disease. You don't have cancer, you don't have any signs of cancer, you're cancer-free. And then at some point, that cell undergoes that change that we talked about, and biological onset begins. And that takes time to develop into a tumor. It may get corrected, it may not. But by the time it gets to a tumor, very early on, there is little effect on biological processes, so it's asymptomatic. In other words, the patient has no symptoms. And then as it grows and starts affecting the body's functions, certain symptoms may arise. So then it becomes symptomatic. And at that point, hopefully the person gets diagnosed and they're in treatment. And then, I mentioned there are 18 million folks in the US that have a past history of an invasive cancer. So then they're in a post-treatment phase. So that's also, once you have cancer, you're at higher risk of a subsequent cancer for lots of different reasons. So we want to be able to keep an eye on those and watch and anticipate further cancer so we can intervene. So the way that we can intervene is primary prevention is intervening before any cancer has started. So some cancers really lend themselves to that because they have a pre-cancer process. So one example of that is in the colon. You may have heard of polyps. So polyps are benign lumps of tissue, but if left over time, they can become abnormal and turn into cancer. So that's one example. Another example of primary prevention is cervical cancer screening, because cervical cancer develops, it goes through a stage of abnormality that's not cancer that you can actually detect on the cells of the cervix before it becomes cancer. So if you intervene at that point, you are preventing a cancer. Once biological onset has occurred, then this is where screening comes in, and I'll talk more about all of these a little bit later. So with screening, what you're trying to do is detect the cancer before it causes symptoms. And so you're really intervening at the phase 2 and 3. And then once the cancers become symptomatic, then you're in diagnosis phase, and we'll talk about that. And then what we call tertiary prevention is once someone's had cancer, we need to monitor them carefully to make sure, A, the cancer doesn't recur, and B, that they don't get other associated cancers as well. So these are our options for intervening in trying to prevent cancer. So how do we get to that point where we identify what our preventive measures might be? So let's talk about risk factor mitigation, or reducing exposure to risk factors. Before we identify something as a risk factor for cancer, we have to have studied rigorously to establish that some kind of exposure results in cancer. So there's a Bradford Hill criteria, which show, certain things can be found with cancer, but don't actually cause it. So to establish that causal relationship is really key and important in the first step to figuring out whether we can prevent it. So there are this is epidemiologic study. So we're looking at strength of association of certain exposures with certain cancers. So when you look historically, there are really obvious examples of this. For instance, in chimney sweeps in the UK, they found out they were getting scrotal cancer. And it was something to do with the dust and the chemicals they were inhaling when they were, cleaning chimneys. So you look for these patterns and then you study them. And then you're looking for consistency of data. The data has to be in multiple places, multiple times, multiple sources. And then it has to be very specific that, that relationship is reproducible in multiple times and places. And there's temporality. The exposure has to happen before the cancer occurs. There's a gradient. So if you get more exposed to higher levels more repeatedly, then there's a stronger association with the cancer. And of course, there has to be a biological plausibility. In other words, there has to be a biological pathway through which that exposure causes the cancer. And then, experimenting, manipulating the exposure to see if cancer happens or doesn't happen. These are usually cellular or animal experiments to test that. And then, of course, clinical research to look at examining that in human data, but also designing experiments and clinical research that controls or prevents the exposure to see if there's a difference in cancer outcomes. So that part is really difficult for prevention because the sample sizes needed are really, really large. And of course, there's ethical implications as well of what we can and can't do with human subjects. So it's not, it's very, very challenging to establish causality. So to get to medical recommendations, all this needs to have happened. And, you know, authoritative societies and guidelines rely on the evidence. And often in this area, you know, the data is really challenging because it's not complete and it's difficult. So here are some examples of cancer-causing factors that have been identified by the International Association of Research in Cancer and also the American Cancer Society and NCI. And you can see a lot of these are chemicals that are produced as a byproduct of industrial processes. But there are other things as well, such as diet, hormones, smoking, sunlight, obesity, infectious agents as well that you may be more familiar with, as well as chronic inflammation. What I want to do is just present you some data on modifiable risk factors. So some risk factors we may not be able to change, but these are the ones that are potentially modifiable. So there's a study that was a really elegant and very impactful study that was done a few years ago, where the authors looked at available risk factor exposure data that was available, and they looked at outcome data for cancer diagnosis from the CDC and others, and exposure data primarily from population-based surveys that go on through the National Center for Health Statistics and the CDC that collects these risk factor and behavioral kind of measures over time. And so they use this data to try and model how much each of these risk factors potentially could be responsible for or contributing to development of cancers and also deaths from cancers. So this slide shows, if you look at the purple bar graphs first, so this shows that if you combine all the risk factors together, that they contribute to about 42, according to their modeling, contribute to about 42% of 42% contribution to the development of cancer as a whole. And cigarette smoking, tobacco, was the highest single contributor at about 20% of new cases. And then there's a smattering of other risk factors at much lower attributable fractions. So if you look at obesity, diet, the low fruit and vegetable intake, alcohol, and physical inactivity, that accounts for about 18%. And then similarly on the death side, their estimates are that, you know, that these risk factors could be contributing to about 45% of the deaths that are occurring. And then they divide it out by the different risk factors. So you can see on here, you know, the top ones, which are the excess body weight, cigarette smoking, some infections, UV radiation, eating processed meat, secondhand smoke, and the infections that are mentioned there that are primarily responsible for liver or stomach cancers. So, you know, potentially these are, if we were able to intervene on these exposures, we could really reduce the burden of cancer. And now if you look at it by cancers and what proportion of a cancer is attributed to a risk factor, you can see that cervical cancer is 100%. And this is because we know from work that and research that HPV, human papilloma virus infection, is a required for a cancer to have occurred. There are no cases of cancers of the cervix that don't have an exposure to human papilloma virus. So you can see kind of the contribution of the risk factors to some of these cancers. And for lung, it's smoking, and that accounts for about 86% of the cases. But when you look by numbers, the attributable cases, you can see I've underlined the ones that are really, really high. So UV radiation and melanoma, smoking and lung cancer, colorectal's diet, primarily a little bit of smoking, but also alcohol. And female breast is a combination of factors, reproductive patterns being part of them as well. And then on this side, you see the deaths. And again, so it's the pretty similar order in terms of how many of the deaths the risk factors are contributing to or responsible for based on their modeling. So what about early detection? So that's the science. We discussed scientific and ethical in the underpinnings of risk factor mitigation, now early detection. So again, rigorous scientific evaluation is needed before medical recommendations are made for the benefit of screening. So these are some criteria that are epidemiologic criteria that have been established for a long time. When you're developing a screening test, it's primarily designed to detect disease when there are no symptoms. Once symptoms occur, that we call that diagnosis. So this is really about early detection before there are any symptoms. So obviously we want to work on important health problems. So that's an easy check. Cancer is a very important health problem. The natural history of the cancer has to be understood so that you can understand whether it's going to be amenable to detection before it causes symptoms. So a lot of work needs to have already happened. It's helpful if there's an early stage or a latent stage at which intervention can prevent, prevent development further. A test has to be available that can detect the cancer. The test has to be not too difficult to do, expensive to do, invasive, that it will cause more complications than you might get from just waiting until symptoms occur. And it should be there should be treatment available. We don't want to diagnose things early if there's no effective treatment, because that has a devastating effect on people. And often, you can diagnose cancer years or decades before they would lead to any health consequences. So that's something that's in the consideration. And of course, the test and the treatment should be available to the population. And then there's an economic consideration in there as well. So with prevention, the threshold for using a test is much higher than if you have someone already with a disease or treatment. Because when you screen or use these tests, the majority of people are not going to be screening positive. So a lot of people will be exposed to the test and the process and the anxiety who are not going to end up having the cancer. So it's a very special kind of consideration for the individual in terms of the benefits of the screening versus the potential harms of the screening as well. Sometimes screening tests have their own harms associated with them. Example, colonoscopy, it does have a complication rate. Mammography, there is radiation, and radiation is known to be a risk factor for developing cancer. So there's a balance always in these things. So it's not as straightforward as it seems. So that's why this process is really important in having done it and producing the data that can be evaluated by medical societies, etc. So based on this data I just gave you an example of one study. Based on this and other work that's happened, it seems like about half of cancer cases could be potentially prevented if we were maximizing risk factor modification and we were maximizing the uptake of screening. And the good news is the cancers that account for almost half of all the cancer cases that we have, so lung, breast, colorectal, cervical, prostate, they're actually responsible for about half of all the cancer cases. So potentially we could have a really significant impact on a population level on these kinds on cancer in the US and elsewhere. So how do we intervene and how do we think about prevention? Well, we have a lot of levers. And if you look at the kinds of risk factors that we talked about, you can see many of them are going to require policies and interventions at that level, at the federal level, the state level, and local level. Policies around environmental contamination, policies around occupational exposures and safety, etc. Policies around healthcare coverage. And then, there's a variety of different ways that at the community and organizational level, the interventions can occur as well. So, some examples of community and organizational level are health system-based interventions to maximize the delivery of preventive services. And going back to the policy, we know that regarding tobacco, there was a significant impact of taxation and smoke-free laws, warning labels, and marketing bans on the uptake of smoking. Insurance coverage is another thing. And, we also reviewed the food and dietary intake component of the risk. And that's, the policies around access to healthy foods can have a significant impact on a population level, although it may be minimal impact on the individual level. So individual level interventions need to happen as well. And these are around exposure to modifiable risk factors, tobacco cessation. These are the kinds of interventions that are really under the kind of auspices of the individual themselves. So it's complicated impacting cancer prevention because we have to consider interventions at all these levels. So what can you do? So this slide shows lifestyle modification. It's not going to be new news to any of you, right? This is what we're told is healthy. There's very robust, strong data about how this affects cancer, but also chronic diseases. Cancer is the second leading cause of death in the US. The first one is cardiovascular disease. They're kind of vying for top spot, and they're very close together. So these risk factors that we want to be aware of and reduce exposure to and maximize are applicable to not just cancer. There's health benefits for just about every single disease, especially chronic disease that we deal with. So I'm going to go into each of these in a little bit more detail. So tobacco, all forms of tobacco have some kind of influence on the development of cancer as the second-hand exposure. I just listed the cancers that there's very robust data for a role for tobacco. And the good news is, if you look at the graph in the middle, that there's been a massive decline in smoking. So the circle line shows the uptake of smoking within adults, and the small one and the little rectangles show youth. So the prevalence of smoking has declined from 42% to 13.7% in the US population. So that is huge and a big win. But having said that, there are still 13.7% of people that are regular smokers. So we still have work to do. And then among the youth, they started collecting data around 1995. And I'm not sure what that little blip is there in the mid to late 90s. But you can see that that's also declined, and it's as low as 8.8%. However, the graph on the right shows e-cigarette use. So that's shown an interesting trend as well. It peaked at around regular e-cigarette use among adolescents was around 20% in around 2019. And then since then, it's declined, and it's slightly edging back up. The reason that's important is, although it's thought to be safer from the perspective of no combustible smoke, it can be a gateway to smoking. So that's the youth that participate and regularly use e-cigarettes are 2 to 4 times more likely to become smokers. So it is important to intervene. And of course, there are other chemicals in the e-cigarettes, and we really don't know what the long-term consequences of those are. So the data and evidence for tobacco cessation interventions is really robust. It's a triple threat that you need for treatment to get the maximal effect. One is counseling, one is nicotine replacement therapy, and the third is medication. And all three together work much better than each alone. And often there are multiple quit attempts that are needed before someone is successful. But it is worth it. When someone quits, you very quickly gain back some life years, 10 years of life gained when someone quits. And the earlier you do it, that goes up. So no matter how far along their smoking journey an individual is, it's always worth quitting. So the second set of factors are healthy diet, so things that you imbibe and eat, healthy diet and reduce alcohol. So the recommended guideline for healthy eating is that half of your plate should be fruit and vegetables, with a focus on whole fruits and whole grains, and varying your vegetables. So you're eating leafy greens and also brightly colored orange, red, vegetables as well, because there are certain chemicals in there that are protective. And dairy is important, but a shift to low fat or fat-free dairy is important. And of course, added sugars need to be avoided, especially in beverages in children. And, you know, as this kind of really nice graphic from the USDA shows, the benefits add up bite by bite over time. Now, how are we all doing on this? Unfortunately, not very well. This is the score that different age groups get for how well they are complying with these recommendations. And the scores are from 0 to 100. So even in childhood, all the way through to middle age and older age, you know, we're not doing very well. We're like C or less. And so there's a lot of work to be continued to do. Recognizing a lot of this could be, some of this can be addressed with policy and environment, but also the individual really has some control to the extent, you know, some control over what they're eating. So following a healthy eating pattern at all ages is important. Nutrient-dense food that helps people get and stay at a healthy body weight, so monitoring body weight and keeping that in back of mind all the time is important. Eating a variety of vegetables, as we mentioned, fruits, and avoiding red and processed meats and sugar, added sugar in beverages and foods, and avoiding alcohol. No alcohol is the ideal as far as risk for disease goes, but limiting it is important as well. So again, I know everyone's heard this, but it's good to see it from the perspective of cancer. And then for healthy body weight is really important. Excess body weight is an independent risk factor for cancers, you know, apart from the dietary things as well. There's a separate component that's healthy body weight. And being physically active is very important. Again, if you're overweight or obese and physically active, there is a benefit. So the two have independent effects. So you can still be an unhealthy weight, but be physically active. You're going to be in much better shape for a lot of chronic diseases as well as cancer. And the recommendations are moderate or vigorous intensity exercise each week of 150 to 300 minutes or 75 to 150 minutes. And ideally, we want everyone to do the 300 minutes. Again, children and teens, they need to have at least an hour of moderate or vigorous intensity activity each day, and reduce screen time and sedentary behavior. So tracking that is really important. Unfortunately, this risk factor is going in the wrong direction. So this graph shows trends in overweight and obesity over time. The solid lines are men and the dotted lines are women. So if we look at the overweight categories, so the blue line, a solid line, you see that the proportion overweight remains basically steady and is actually declining in men. And in women, similar pattern. It's basically hasn't moved much over the last 50 or 60 years. What has changed, though, is the proportion that are obese. So that has risen dramatically since the 80s, you know, a very dramatic rise and continuing to rise. So we haven't really made any inroads there with all these recommendations and the few policy changes that have been put into place. And at the bottom, you can see severe obesity. how that has also increased. So right now, about 70% of people are in the US are overweight or obese. So let's shift to early diagnosis. So we're going to talk more about early detection and screening in a minute. So let's do early diagnosis. So personal preventive behaviors. So now cancer is, as we mentioned, a very varied and diverse disease. And no two cancers present the same. Biologically, they're not the same. Different people can get different symptoms or no symptoms at all. But it is important that people be aware of their bodies and be tuned in to detect changes that occur. So as I said, no symptoms very often happens in someone that has a cancer. So that's where screening is really important. But unfortunately, we don't have the data, the tests, or the treatment, or the biology of the cancer to be able to screen for every single kind of cancer. Unintended weight loss, fatigue, just generally, swelling, pain, bowel changes, skin changes, fever that's unexplained, bleeding after menopause, a sore that doesn't heal, a persistent cough, difficulty swallowing, unexpected bleeding or bleeding with very little trauma, enlarged lymph nodes, persistent indigestion, night sweats, changes in the breasts, a change in appetite that's persistent, nausea, again, that's persistent, bloating, blood in the urine, headaches, vision changes, changes in bladder, and shortness of breath. So you see, these symptoms happen in a lot of different diseases and conditions. They're not specific to cancer, which is why it's really important for us to be aware and to take notice of when these happens. But you have to see a healthcare provider who can examine the kind of nature of the symptom or the sign and look at associated symptoms and come up with potential things that could be causing it and whether it's likely to be cancer or not, and then so on. So seeking healthcare is very important because for two reasons. One, the symptoms. So you want to be able to present to your doctor or your provider to discuss your symptoms, but also for screening. And that's what we're going to talk about next. That's the early detection. So family history is very interesting. So a minority of cancers run in families. So if you have a family history, then it's important for you to seek screening and get evaluated for your risk. But that doesn't mean that you're going to get that cancer. On the other side, if you don't have a family history, it doesn't mean you're not going to get cancer. So family history is helpful in gauging your risk, but it's not a predictor. Its presence or absence is not a predictor of whether you're going to get cancer. Most cancers that are diagnosed are in people that did not have a family history of that cancer. So, you know, you often hear patients say, well, it's not in my family, so I'm okay. No, that's not true. Just as the opposite, oh, I have a family history, I'm going to get it, is also not true. So it's helpful, but it's not, it doesn't help in figuring out how susceptible you might be to a cancer. So discussing your family history with your provider and identifying what screening test would be beneficial for you is really important. And that has to happen at a healthcare setting. So here are some examples of interventions, vaccines, and testing that are recommended for screening. And then we're going to talk more about the screening tests in a moment. And then seeking assistance for behavior change for risk factor modification. You know, people can do this by themselves, but there are, you know, for tobacco cessation, you may need the prescriptions and so on. And you can get counseling for nutrition or physical activity or help with physical therapy so that you can kind of learn how you can maximize your own body in trying to lose weight or at least becoming regularly physically active. And then, of course, discussing any symptoms and signs with a healthcare provider to get an assessment of whether of what the diagnosis might be and what tests might be recommended. And of course, completing the recommendations of your physician is an important part of prevention. So what are the recommended screening tests for people at average risk of cancer. So these are not special cases where there's a, there may be some inherited condition in your family or something like that. These are people that might have a family history or not, but mostly these tests are determined by your sex and by your age. So we start screening for cervical cancer in women at the age of 21. It's recommended up to the age of 65 with a pap smear or an HPV test. In colorectal cancer, there are a number of tests that are recommended. The recommendations recently changed to 45 to begin screening. It used to be 50 and is recommended till 75. If you're older than 75, it's a shared decision-making based on your patient's preferences, expected life expectancy, other diseases, and prior screening history. For breast cancer, the current recommendations are 50 to 74, and it's every other year mammogram. The American Cancer Society has slightly different recommendations, and is right now shared decision-making between 40 and 50 is recommended. These recommendations are being reviewed right now by a very authoritative body that makes these recommendations, and the draft is that they will reduce the age at which you start screening from 50 to 40 based on available evidence. Lung cancer screening is a relatively new screening test that's kind of come into the recommendations, and this is a spiral CT. It's a CAT scan that's recommended annually for anyone that's either a current smoker or who quit less than 15 years ago. The uptake of that is very low. Prostate cancer is a shared decision-making test. It's not routinely recommended. If it's the preference of the individual, then it can be recommended, and that's based on less than robust evidence and considerations in the efficacy of the test to identify types of prostate cancer that are actually going to be invasive and lead to death, versus benign forms of the prostate cancer that people live with for years and won't be the cause of their death. So it's very complicated. I'm simplifying it a lot. So people aren't getting these tests, and I'm going to show you on the next slide what the data is. We're not maximizing the use of these tests. Ideally, these would be 100% involvement and uptake of these tests, where we're nowhere near that. And these are some of the reasons. There's complicated reasons. Some are logistical, insurance, cost, access. Some are complicated beliefs and kind of trust issues, emotions, fear, embarrassment. Some are related to awareness and knowledge. Some are just, there's so much going on in life. There are competing priorities, and people don't make the time or can't make the time to take care of their health. So this one shows those recommended screening tests, what the uptake is. And you can see that they range from only 3.9% for the lung cancer screening up to about 82% for cervical cancer screening. So that's the one we do best at. And what this table is designed to show you is the overall stage at which people are diagnosed. So in the cancers with very low screening rates, they tend to be diagnosed at a later stage, and their survival is worse. So it's showing that relationship between screening and stage, and then stage and survival. So it is important to get these tests. So summary. Some data I didn't share with you is just coming out around cancer rates in the under 50s, especially in the 40 to 50 range. You saw in the beginning of my presentation that cancer rates and mortality were declining, but one group in which they're increasing, it's a lot lower rate. It's like if it was on the same graph, it would be like at the bottom. But although the rates are lower, the direction is going in the wrong direction. The rates are going up 1 to 2% each year. Screening tests are being underutilized. Risk factor prevalence is not going in the right direction, especially for excess birth weight and a diet and so on. There are disparities in outcomes by non-medical drivers. Good news, rates of new cancers are declining overall. Death rates are declining. Screening rates have increased over time. We've made a significant impact on smoking, and there's a lot of promise for new technology and support for personalized treatment. And the good news also is that, you know, we think we can prevent about 50% of cancers, and with early detection, we can reduce mortality further. So just a word about what we're doing at Dell Medical School in the last few minutes. So we have a cancer prevention and control program. I'm leading that at the moment with a team of people that are working on maximizing prevention in terms of risk factors, but also screening and early detection across the cancers that are listed here. Our footprint is statewide, but we particularly focus on Central Texas area, and we're looking at disparities. We're looking at addressing health equity issues. We're looking at how to do really well-informed decision-making, health communication. We're looking at clinic-based interventions and how can we maximize the delivery of screening to patients that come and see us, and even patients that don't come and see us, but that we're responsible for. And community-based approaches as well, really being in the community, educating, promoting, trying to make the tests available to populations that don't have access, particularly Eastern Travis County and some of the rural areas. We're looking at outcomes that matter to patients. We're looking at how we can support our clinics, especially those serving the uninsured, underinsured, and safety net populations. How can they better deliver services to meet the needs of those patients? And we're looking at health promotion interventions. So we have about 3 minutes left. Thank you for listening. Thank you for inviting me. I hope you learned something today. And some of it may just be revising what you already knew. So I can take questions if we have time.
Yeah, so I'm going to do these kind of rapid fire since we have very little time left, but we do have some great questions here. So the first one is, how can individuals become more effective in requesting and advocating for cancer screenings and prevention with their healthcare provider?
Yeah, I think that, you know, I'm a family physician. I'm also a scientist, but, you know, I really appreciate it when patients come in and they come in with a list, and they are discussing that even before they get to the doctor, they're discussing it with the MA, and they're knowledgeable about these things. Most physicians know this, and their systems are equipped to do this. What we don't really have the capacity and time for in our horrible healthcare system is that we don't have the time to really discuss the pros and cons and do the level of shared decision making and discussion that we were trained to do and we would really want to do and like to do. So that's a system issue that's really hard to deal with. So, you know, those are kind of the quick things I would say.
Yeah. I'm going to combine two. Is there a list of specific fruits and veggies that might be ranked higher or more effective than others? And quick thoughts on whether fasting, whether it's extended or intermittent, helps with, you know,
Okay,
prevention.
so
Mhm.
those are not easy to answer. I can
I
answer the first
know.
one more quickly. Yes, there is evidence that there are chemicals in certain fruits and vegetables that are likely to be more beneficial. So cruciferous vegetables, so these are the least favorite of everyone's vegetables, unfortunately. Broccoli and cauliflower, Brussels sprouts, those have high levels of chemicals we think that would be beneficial, as are the brightly colored fruits and vegetables, like the tomatoes, the peppers, the orange, red, yellow kinds of fruits. And of course, spinach is always good. Regarding the second question, that could be a whole topic of conversation. I don't think I can weigh in there.
No, that's fine. We'll move on. Are there lung screening recommendations for patients who are subject to secondhand smoke? Is it
No,
different? Okay. And
no.
then last question is back to foods. Let's just, is there evidence that eating organic fruits and vegetables does anything different than regular fruits and vegetables for cancer screening and cancer prevention?
Okay, again, that is a complicated question, but quickly, you know, organic fruits and vegetables theoretically are not exposed to some of the chemicals and pesticides that non-organically grown are. So that's an immediate benefit. There are, but there are the way something gets classified as organic or not. There's a certain percentage of the produce from a farm that has to be like that, but it's not 100%. Also, there is some data that suggests the nutritional content of food that's grown organically is a little bit different and perhaps better than the nutritional content of food that's grown non-organically. But they're small studies, and it's a very, very complicated question to answer. But definitely the kind of herbicide and pesticide exposure should definitely be lower in organic foods versus non-organic.
We are out of time. We do have a couple of questions that are still left, but thank you for putting those questions in the QA. And thank you, Dr. Shokar, for being with us today. Everything you presented was wonderful. We were all enwrapped. So we all listened to the whole thing. It was great. Really appreciate you. And thanks to everyone, all the Texas X's who tuned in today. Just FYI, our lunchtime lecture series will be back in July. Kathleen Brady Stimpert, the Deputy Director of the Landmarks Program at UT, will be discussing the public arts collection here at UT. So you can register for that at texasxs.org/lunchtime lectures. Thank you again, and y'all have a good day.